As Rochelle was indicating, I'm Mandana Khalili, Professor of Medicine and Director of the UCSF Research Coordinating Center's Investigator Development Unit for the NIMHD Health Equity Action Network. I'd like to welcome you to our monthly training webinar. Before we start, we'd like to acknowledge the Ramaytush Ulani people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ulani elders, past, present, and future, who call this place the land that UCSF sits upon their home. We're proud to continue their tradition of coming together, growing as a community. We thank the Ramaytush Ulani community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Wonderful. Today we are honored to have Dr. Joanne Spetz speak to us on health policy as it relates to health systems access, quality, and disparities. Dr. Spetz is a director and Brenda Jeffrey Kang Presidential Chair in Healthcare Financing at UCSF's Philip Lee Institute for Health Policy Studies. Dr. Spetz's research focuses on the economics of the healthcare workforce, organization of healthcare services, and quality of healthcare. She directs the federally funded UCSF Health Workforce Research Center on long-term care, which generates evidence to ensure an adequate workforce providing patient-centered care to individuals with long-term care needs across the lifespan. She's an internationally known expert in the nursing workforce, leading studies on nurses' supply, demand, education earnings, and contribution to the quality of care. She's also an Honorary Fellow of the American Academy of Nursing. She received her Ph.D. in economics from Stanford University after studying economics at the MIT. Dr. Spetz, welcome, and we look forward to your presentation. Thank you.
Oh, thank you. And I think as we discussed, we'll be keeping an eye on the chat for burning questions. And then I'll try to have a couple breakpoints for any questions or conversation we want to have. I probably have more slides than our hour, so we'll do what we can do because I think there's a lot of room for dialogue. So I'm going to get my screen sharing going. And make sure that that's up. And then I'm going to get, let's see, I'm getting all the various windows open so I can see the attendees and also get the chat up, which I won't do a great job of keeping an eye on, but I'll kind of try to keep an eye on it at least a little. All right, I think we're good. Okay, first, my disclosure is I'm an economist. What does that mean? We don't find a lot of economists in a lot of health sciences campuses. There are usually a few. And economics is really the discipline of thinking about how societies, communities, groups of people, individuals make decisions when they have scarce resources. So unfortunately, it does not mean how to get rich as an investor, because if it did, I'd be retired already. It really is, in my mind, for healthcare, a policy-oriented discipline that creates a structure around how we think about trade-offs. And so I think you will see this notion of trade-offs really embedded throughout what I'm going to discuss. And that from a policy standpoint is always worth keeping in mind, that anytime a policy is being proposed, there is usually some trade-off that is being made. I tend to be an optimist, so I often believe that there are policies that can make everybody better off and that can meet all the different political competing goals that people have. And sometimes my optimism gets beaten by the reality of the political and policy world, but I'm still an optimist. So you'll also see some of that reflected in some of my comments. So I want to just start with some data that I think is always worth reminding people of how much money do we spend on healthcare in the and this is just the US. In the United States, we are spending nearly $4.5 trillion. It is by far the biggest single item that is spent. I remember my brother coming home from some music festival one day with a bumper sticker that said, you know, US spends more on the military in 1 week than it spends on healthcare in 1 year, which is a really great slogan, but it's actually not true. The US spends more money on healthcare than pretty much anything else in the federal budget. And it's just an extremely big part of our economy. It is over $13,000 per capita in the United States, which I'll put some context around, but right, it's a lot of money. The national health expenditures per capita also just have been on this kind of continuous rise going back into the 1960s. For just history reminder, 1965 is when Medicare and Medicaid were established in the US. And so you really started seeing a lot of growth in healthcare costs in that period of time, because now there was a national health insurance scheme for older people and for people with low incomes, primarily aimed at children with low income. But even with those programs being viewed as quite mature, we continue to have increases in health spending. The US is truly an outlier in this. So this is a chart from the World Bank, and this is a few years old, but if I had newer data, it would look pretty much the same. You can see the United States on the way out there to the right on the horizontal axis about per capita health spending. And then the vertical axis is average life expectancy. So we are a huge outlier on per capita health spending, but our average life expectancy is below that of countries that spend less than half of what we do per capita. So when people talk sometimes about flat of the curve medicine, this is what they're talking about. We're spending more and more money, but we're not necessarily making our population healthier. And there may be other factors, such as we have a diverse population. We have a population that has, we welcome immigrants from all over the world who may have different historical health, human capital, and kind of social capital, and that those are significant issues that maybe affect our average life expectancy. Okay, that's fine, but the Commonwealth Fund has done health equity comparisons, and in addition to spending more money than every other country in the world per capita, we actually rank among the lowest in health equity. So this is, in my mind, I think, an introduction to what I view as the crux of the policy conundrum. So I'm going to try to make you really depressed. So who pays for all of this? Lest one make the argument of, oh, the US, though it's such a private spending-oriented healthcare system, that's actually not true. Roughly half of healthcare spending in the US is coming from the government. And where you look at the remainder of spending, 27% is coming from households. So that's insurance premiums, that's co-payments, that's what you pay at Walgreens when you're buying something on your own. And then private businesses is 17%. That's employer-sponsored health insurance. Those private businesses, I mean, that money is not coming out of Jeff Bezos's pocket. That essentially is money that could be going to two places. It could be going to more wages, or it could be going to more, shareholder wealth. But there is research evidence that at least some of that private business spending is resulting in lower wage growth for people who are getting health benefits instead of wages. That might be good, right? That might be a good thing. But given how much money the US is spending on healthcare, maybe it's a little extreme. So this chart is the percent of health spending from public sources. And you can see kind of the jump in the middle of the chart that is when Medicare and Medicaid were established. And the blue line also reflects kind of subsidies for private spending, which is really associated with the tax break that people get on their health insurance premiums. Your health insurance premium is essentially, if you're getting it through your employer, it is essentially a tax-free benefit to you. And that's essentially a subsidy that's coming from the government. So that's part of what this is reflecting here. So the government is spending in the US a lot of money. So anybody who wants to claim we don't have a socialist healthcare system is just wrong. Half of our spending is coming from a socialist government healthcare system. Nonetheless, we still have a lot of people who don't have health insurance. This chart's from 2021. I was trying to find the exact same one for 2023, and I could not find it posted on the Kaiser Family Foundation website. But what I like about this one is this shows you the racial and ethnic disparities associated with uninsured rates, with Native American, Alaska Native having the highest rate of uninsured, and people who are Hispanic or Latinx descent or self-identify as that identity have the next highest rate of being uninsured. And over on the right, you can see expansion states and non-expansion states. One of the things that happened with the Affordable Care Act is that it was originally designed that every state would be required to expand their Medicaid program to broader numbers of non-elderly, non-children populations. And the Supreme Court ruled that that mandate was not constitutional, which surprised most observers. And so a number of states, even in 2021, have not expanded their Medicaid program according to what was proposed in the Affordable Care Act. So you can see that the uninsured rate in those states is basically double what it is in the states that did expand their Medicaid programs. And those states are big ones, including like Florida and Texas. So it's significant numbers of people who are affected by that failure to expand the Medicaid program for people with low income. So the problems that we see in our system are pretty deep, and I think you all know this, so I'm not going to spend a lot of time on this. Quality of care issues and access to care. Some recent data reported that US residents receive less than 9% of the recommended evidence-based preventative health care. That's way lower than I thought. The last citation that I had seen was more like, 40%. So this, but this was a pretty rigorous methodology and really depressing. Individual expenditure. So the average family health insurance premium is nearly $24,000 in the most recent data that Kaiser Family Foundation posted. Median household income was just shy of $75,000 in that year. So health insurance is costing nearly 1/3 of a median household income. Who can afford that, right? If you are below the median in your household household income, how can you afford that family insurance premium? And thus there are subsidies, right? There are various subsidies and such, but they, but they are for many families not sufficient. Natasha, that's a great question about whether that recommendation includes dental care. I would bet you it does not. The link is at the bottom of the slide, and I'm happy to share these slides so that you can grab the link more easily than trying to type it in from this. But I am pretty sure that does not include dental services. And in most of these data, I mean, dental services are included as part of health expenditure, but in a lot of this data, like health insurance premiums don't cover dental care typically, because for some reason that I have never fully understood, the head is not connected to the body, and thus behavioral health and dental care are viewed as these completely separate healthcare systems and not always included in our policy and understanding of healthcare delivery. Makes no sense. Go figure. So, there are parts of the brain, like your eyes apparently are part of the health system, but your teeth and your behavioral health, your mental health are not. I have no explanation other than just to shake my head. And then, of course, national healthcare spending. The US is about 1/6 of the economy. And from a policy standpoint, it's important to keep that in mind. Apart from, feeling frustrated about how much money the US is spending for so little additional value or equity for that, one person's waste is another person's paycheck. A lot of people make a lot of money on this, including clinicians, including not the public health sector, I assure you, but clinicians, hospitals, insurance companies. This 1/6 of the economy is spread across jobs, right? Job growth, healthcare has been viewed as the job growth engine of the US economy. So attempts to reduce national health spending do have potentially real implications, including for low-wage workers that work in this industry, and are the reason that there is often so much lobbying against efforts to reduce healthcare spending, because it's somebody's paycheck that it would be affected by those kinds of reductions. In health policy, many people talk about this healthcare triangle, that it is almost impossible to touch one side of the triangle without changing the length of the leg of the rest of the triangle: cost, access, and quality. It's very difficult to talk about improving quality of care without inadvertently or intentionally affecting cost in some way. Often quality improving activities do end up costing more money in the short term. Maybe in the long term they save money, but in the short term they might say they might cost money, or typically do. They also may have implications for access. If quality improvement activities raise the cost of healthcare, that makes healthcare less affordable and less accessible to a bigger share of the population. Similarly, when you talk about expanding access, that might cost more money. That may not have any impact on quality, but the pressure on healthcare costs may then result in pressure on quality issues. So these things need to often be talked about, or at least thought about holistically, because they do tend to affect each other. And healthcare cost really is, I'm an economist, so I'm biased on this, but fundamentally, the amount of money that we spend on a system that is not equitable and is not actually making many, many people as healthy as they could be, we're doing far worse than like pretty much all of Europe, gives us a lot of room for policy change, and we need to think about how to do that without spending more money. So for reform to occur in the US, there are a number of policy propositions I'm going to put out there that I think help illustrate the scope of the policy problem. One is that, honestly, we have to buy into the idea that healthcare should be more equal or more equitable, however we want to define that. But we need to buy into the idea that there should be some baseline of care that is equally accessible to all people. If there is not a fundamental social agreement as to what that is, it's very hard to make headway against the health policy problems. Now, this is a really big lift for a nation as large and diverse as the United States. Every European country has some kind of national health insurance system. But I posit that if you told the European Union that they all needed to sit in a room and agree to a single, unified, consistent national healthcare system that would apply in every EU country, they would never be able to do it. And that really gives you a sense of the enormity of trying to imagine the US, every state, every subsector, every subpopulation in the US achieving agreement on what a single national health system would look like. It may not actually be feasible from a political or a policy or a social consensus standpoint, which is why you've seen so much action at the state level. It's why you saw Hawaii actually have a state type of employer mandate system a good 20 years before Massachusetts established their big health reform. And California is talking about trying to move towards a universal coverage plan, Healthy California for All. And that is a slow process. Oregon has talked about it. Vermont has talked about it. We are likely in this country to see traction at the state level long before we see any real consensus nationally. And that may, I don't know if I'd say that's a good thing or a bad thing, but that may be the necessary thing. That people can think more about equality and equity in healthcare from a policy standpoint when they are imagining their neighbor or somebody across town or somebody in a small state like Vermont, somebody they might run into. Even if they live across the state, they might run into them shopping. Whereas when you're looking at a bigger state, it's harder. And we're looking at a giant nation that's, as big as like all of Europe, it becomes really difficult to imagine. So it's just worth kind of tempering our optimism in that regard. We also would need to approach our national well-being collectively, and that gets difficult because and I think it's become even more difficult because there's been so much rhetoric around kind of othering people who are not part of your kind of local tribe, as it were. And that is really a huge barrier to equity and understanding. And the self-segregation of populations is, I would argue, probably making that worse. So we need more trust in government. We have a lot of reasons to not trust our government, and that's very much at the core of the U.S. identity as a nation, right? These were all the people who did not want to report to the king in England, and then did not wanted to have a revolution. And it's very much deep in the U.S. culture to not really trust your government or leaders, and that has gotten worse, not better. And we have to acknowledge that we do have scarce resources, so we need to be able to think about how to allocate them well. And just acknowledging that, you have to make trade-offs, that if you put more money into healthcare, that's less money for schools, that's less money for roads, that's less money potentially for the military, which, depending on your point of view, those are trade-offs that you might view as good. Those are trade-offs that some people would view as bad. But we have to acknowledge that those trade-offs are part of the discussion. There are also really fundamental ethical and philosophical debates in the health policy arena to be attentive to. And economics is a fairly, in many ways, can be a conservative discipline. And so I mean, this is very steeped in the kind of academic world that I grew up in, is kind of that how to think about these different dimensions of ethics. Terminology around access, rights, justice, and fairness, these all have very different meanings to different people. And that's important to recognize, that one person thinks of as the right to good quality healthcare is viewed by another person as actually they should have the right for full individual freedom. And which of those rights is more important? You can't really say that one of those is right or wrong. People have different philosophical views and ethical views of these questions. Is access to healthcare truly a right? Is it a transnational human right? The WHO clearly says that they believe it is so, and I personally believe it is so. But is it given by the Constitution? Not really in the US. Where does that right come from? And defining that clearly is very important. It may make more sense to define it not as a right, but as a point of justice and equity, and as opposed to a right, because that terminology gets kind of fraught given the way the US government is structured. And how does one balance the protection of individual freedom while also promoting fairness? Fair does not mean the same thing to everybody. What one person perceives as fair is not necessarily what another person perceives as fair. And so that even just unpacking what people mean by that when they use that terminology can be very helpful in a policy debate. So this is my one semi-technical concept slide that I'm going to provide that I think is the fundamental problem of health policy. And every nation, no matter how they define their healthcare system, I think faces this challenge. So economists love to draw these charts, and so bear with me. On the vertical axis is the marginal cost or the marginal benefit of care, meaning if I gave you one more unit of healthcare, how much benefit would you get and how much would it cost? And just imagine it's all in dollar terms, even though that's kind of a stupid way to measure benefit, but just, put it on the same axis. It makes life easier. The horizontal axis is the amount of healthcare received. So just as a stylized fact, generally we tend to think that the more healthcare you get, the additional benefit of each increment is probably a little bit less. At the lowest levels of healthcare, it has a huge benefit. Think about vaccination. Think about antibiotics for bacterial illnesses. Think about, various treatments where a small amount produces a huge benefit in health. But as you go further out, additional healthcare has less and less benefit, and actually at some point could make people worse off, right? Think about over-screening, too much surgery, right? Like doing a biopsy on a 92-year-old frail older person who has a suspicious lymph node, the probability that you're going to make that person worse off with a surgery is fairly high. Emily Finlayson, who's on the UCSF faculty, has documented that you make people worse off in certain circumstances with certain kinds of treatments. So more healthcare can make people worse off. So if the true cost of delivering healthcare is just on this stylized, on this horizontal line, let's imagine this is a single procedure, like, I don't know, doing, giving somebody a medication. A little bit of the medication goes a long way. At some point, you've had too much ibuprofen and now you've got stomach ulcers. The cost of the ibuprofen is your horizontal line. And let's imagine it's insurance coverage. But with the insurance coverage, the price that you see as an individual is lower than what it actually costs society to produce it. You only see this lower price because you have insurance, you have a copayment. So in theory, you want to consume the amount where the cost intersects with the marginal benefit. And the reason that logically, if you consumed more, the cost is now higher than the benefit you get. And so you don't want to. And if you consumed less, the cost is now less than the extra benefit you'd get. So you should get more. You should buy more of it. And so the optimal quantity from a social perspective would be at that point that line is pointing to. But we as patients, if we have health insurance, see this lower line, see this lower point. That's how much care we want, right? I have an insurance premium covering me. I only pay $10 when I go to see, well, $20 for, I think, my copayment. So I pay $20 if I go to see the provider. If I actually had to see the full cost, the $120 or whatever it is to go see the provider, I might decide not to go. But if I only pay $20, then I'm more likely to go. I'm more likely to seek that care. Every healthcare system, whether you are mostly in private insurance or you're the US British health system, or sorry, the UK National Health Service, where you've got a fully nationalized health system, every system has to try to deal with this problem. How much care is too much care? How do you convince people that it is above the social optimum? Because the pressure is always going to be for people to want more care than the social optimum. And they might not want the right kind of care, right? They might not be asking for more preventive care. They might be asking for more, I want an MRI on my knee today because I fell and it feels a little funny, which, most rehab medicine physicians would say, ice it and let it rest for a week. And if it's not getting better, then we'll spend all the money on an MRI for you. But everybody wants to get their MRI today, and because it's insured, why not? So people ask for care that isn't necessarily great care, and it's not their fault. So we can't blame the individuals for wanting this care. Of course, people who don't have health insurance are stuck in that they don't even get these options for care. So shortfalls in healthcare are a significant cause of premature deaths. And we should just keep that in mind, that people, and also there are a number of other factors that cause premature deaths. There are behaviors, there are genetic predispositions, both of which have broad structural racism issues behind them that we could spend, I'm sure other people have talked about in this forum. But you also have social circumstances and other factors. But shortfalls in healthcare are a part of premature deaths, but maybe most estimates are that it's probably only about 10%. So complex patients really fit into this. If you look at populations, for example, say frequent users of emergency departments and people who have frequent rehospitalizations, typically those populations have a lack of access to continuous services. So there's a fundamental access to care issue. Medicaid, we know, generally pays poorly in most states. So for people who have low incomes and are enrolled in this program, you have a lot of people where there is not a great set of providers or not a very large set of providers available to them. And of course, a lot of people are not insured at all in the United States. And then social care is often the primary need. And that includes not only like needing to address the physiological needs of individuals for housing, for good food, their safety, their social environment, their psychological environment, their sense that they are respected as members of societies, and their ability to self-actualize. Healthcare is probably somewhere maybe in the middle of this set of needs, but it's very hard to make a lot of traction in improving health without addressing the full set of social needs that people have. So we all live in these systems and structures, and these systems and structures are living in us, and these structures are not neutral, and they enhance or impair life outcomes. So when I think about health policy, I do not limit that to health policy strictly defined. Health policy has to be defined broadly, and policies and programs affect health factors, and those things affect health outcomes. So, so this is a model. I forgot to put the citation on it. I'll find a link and share it out, where this came from. I think this is related to some of the state health policy rankings. And some of the framework on that is thinking about in the health factors, you've got health behaviors, you've got clinical care, you've got your social factors and your physical environment. And these all contribute to health outcomes, which are not just the length of life. I mean, I presented a lot of charts that were on life expectancy, but quality of life needs to be part of that. Or as my grandfather always quipped, why live twice as long, half as good? Extending life may improve the quality of life, but in some cases, extending life actually is detrimental to the quality of life. And that is, all part of the nuance and the difficulty. So I'm going to take a quick pause because I think this is kind of a good spot if there are any opportunities for discussion or any questions or anything like that. So I'll stop my share briefly and just look for Zoom hands or look in the chat. Maybe not.
Thank you, Dr. Spetz. Maybe, oh, there we go. Dr. Opara, please go ahead.
Yes, can you hear me?
Yes.
Yes, we can hear you.
Yes, thank you for a very fascinating presentation so far. I put in the chat health in all policies, and I wondered if you can explore through that lens in connection with what you're outlining currently to the point that you make that, again, we can look at, health doesn't exist in a vacuum on its own, but that it's really part of, again, the social and structural context in which people live. And I love what you said, that not only the fact that we live within this context, but these contexts live in us. And that's really important, and because literally lives in us as it shows up in our bodies and on our bodies in terms of health and other outcomes. And so what does that mean through the lens of for not having isolated, separated health policy, but looking at policies about anything, but through the lens of health? In other words, a health in all policies, regardless of what that policy is focusing or targeting.
Yeah, I mean, you were absolutely right that health is affected by so many different policies that we have around all different spheres of our lives. Somebody pointed out to me, I don't have the data for this, but there was, I was in an international conference and somebody said, or hypotheted, that if you looked at, say, England, where their per capita healthcare spending is much lower than the US, that their per capita social spending is much higher than the US. They have a much more robust social safety net. And if you added those together, this person's hypothesis was that it's probably pretty similar to what the US spends. We have, for lack of a better word, we have a crappy social safety net. It's got holes and there's whole parts that aren't even covered. Like, if you're over there, the net just doesn't even exist. If you're a migrant farm worker, what social safety net? Forget it. It doesn't exist. And so that, so without that social safety net, that also probably necessitates some of the extra spending on healthcare that we have. And also, we still get very little for it because that money might be better spent in the social safety net. Whereas in a lot of European countries, the social safety net is very robust, and that has additional benefits in terms of their health outcomes, relative to the US. And so, and economists sometimes will say, depending on their point of view, that putting more public resources into a national health system is, in the big picture, potentially a fairly inefficient way to improve health, and an inefficient use of resources from kind of an economic perspective. That economically speaking, we would be better off giving people more earned income tax credit, more a universal basic income, all of these other options financially that would give individuals more choice and provide them with the ability to say, you know what, I don't need a better health insurance plan. What I need is better food. And what I need is a better housing. And what I need is to live near a place where there's a park, so my children can run and play, and I'm less concerned about them developing obesity. And so, so there is kind of a line of argument that rather than focusing or putting more resources specifically into healthcare, which there's a large lobby that would like us to do, maybe we should be putting our resources into broader policies that are more agnostic about individual choice, such as universal basic income. And then, of course, you get a lot of paternalism, like, well, if you give those people money, they won't use it right. And it's like, oh, come on, like, talk about paternalistic points of view. But that's a bit of a digression. I'm going to go back to the slideshow. So, so thinking about that first chart about a little bit of healthcare goes a long way. The worldwide, and the US in particular, has had some really, really amazing public health and policy achievements in the 1900s. And, if we want to think about like health policy doesn't matter, all you have to say is, like a lot of the early childhood vaccinations and making a lot of those mandated early on, which is backed off from a policy standpoint, but for the period of time where there was a lot of mandate that pushed them out, there's a huge public health achievement. Motor vehicle safety has had tremendous public health and life expectancy and injury benefits. Occupational health and safety requirements, safer and healthier foods. I mean, there's still a long way to go on that, but we have made a lot of progress in that area over the past 100 years plus. We've had big interventions in both medical discoveries and in increasing access to interventions that reduce the risk of death from coronary heart disease and stroke. We have had improvements in the health of mothers and babies, even though the US is one of the areas where the US lags way behind other countries. Fluoridation of drinking water for dental care has had documented benefits. Tobacco control, and just in general, the control of infectious diseases. So there are a lot of areas where we've had these kinds of benefits. But we still do have these structural racism issues from policy that I believe we need to address. And I think we need to come up with ways to describe these that are nuanced, and that people who recoil at the potential idea that you were accusing them of racism understand that this is really about structures and not about them individually. That we have structural pillars of society that embed these things, that most people, when asked about it in detail, will admit that these things are bad to be structurally, defined, and don't fully appreciate it until that conversation is had. So I feel like in this space, I can often say structural racism, but in other spaces, you may need to use different terminology. But there are processes and that are social and also that are created by these structures that lead to producing various disparities in results. And, so this is like taking the Donna Beattian structure process outcomes model and applying it to the concept of racism. And a lot of different policies, align with that per Dr. Opara's comment. about health in all policies. If we go back to redlining, which was related to home loan and housing kind of covenants and neighborhoods, redlining resulted in inabilities to get home loans. It affected the tax base in communities, which then affected rates of poverty, funding for schools, which then play out through a whole set of different pathways. That one of the many different outcomes we see is poor health outcomes, but that is just one of a whole series of different structures that we see. And I would argue for health policy, we can point to a number of different places where we can have policy interventions that would affect the outcomes. All of those things I circled there are not actually more healthcare, right? These are all things that may have a bigger impact on health outcomes. For example, if you look at SAT, standardized college exam, entrance exams by income, huge correlation there, which would go back to a lot of the different histories of what makes schools well-funded, what makes schools do better. And people have tried to look at this and say, well, this is because of differences in parents' education and blah, blah, blah. And that's all fine and good. But what we see this play out to, regardless of its origins, is you do end up with different percentages of populations with bachelor's or higher degrees. And we also see differences in infant mortality across both racial groups and educational groups. And it's important to note that those racial group differences are persistent even when you try to control for differences in education, in income, in all these other factors. You still have race. In my multivariate regression, race still comes up as a dummy variable, as a significant predictor on its own. And that I interpret as that's all the structural racism playing out in ways that we can't even fully understand it and measure with the models that we have. Other people try to interpret in different ways, but and I was trying to find a newer version of this table, which I could not find this exact chart. But we know that these correlations between income and education are very persistent, and they play out into premature mortality, as well as birth outcomes, as well as all kinds of other things. So getting a little bit into the health policy pieces. I'm guessing that most of you have heard about the triple aim, which was coined by Don Berwick, who is a health policy thinker and leader. And the triple aim in his mind was that you were trying to improve the individual's experience of care and the quality of care that the individual gets. That is really part of a goal of trying to improve population health as a whole. So you want to improve the individual health, but really you want to think about your full population, your full community, your full nation, your state, whatever level you want to view the population at. And at the same time, you should be able to lower the cost of care. And your goal from a policy standpoint and a practice or leadership standpoint, he would argue, is that you should be trying to achieve all three of these things at the same time. And that is a marker of good policy. Some people have tried to add like, oh, and then there's a fourth aim of sustainable jobs. And I think that's a great fourth aim, because you don't want to do this you don't want to put so much burden on people trying to achieve this that you burn everybody out. But there are, but really the core of it from a policy standpoint is what policies can we implement that will achieve these three things. So in our healthcare system, we have a lot of different levers. Education and research, right? Our professional schools are one of the areas where we have a lever. Who are we educating? How many are we educating? How are we educating? Should we be educating more physicians, or should we be educating more medical assistants at a higher level to be more proficient in the care team to relieve the burden on physicians and help partner with them? All points for debate. Suppliers, drugs, equipment, those are components of the health system where there are a lot of regulations and there can be levers for policy there. We've got insurers that have kind of two different flavors. We've got the government insurers who are inherently policy, but then the commercial insurance market is also very heavily regulated. We've got the payers, which is really typically the insurers, but also would include public health. Some state agencies do direct payment of services, and people self-pay, right? There's co-payments, there's additional costs. And then you've got the providers, the clinicians, the hospitals, the long-term care. It's a very broad set of providers out there in the market. Yes, and Dr. Opara, you're totally right. I have seen quintuple aim of health equity. And I would personally, I tend to put health equity, I would throw that into the, although improved population health outcomes, one would think embeds health equity in the best of all worlds. Lots of different proposals around that. So if we look at where the money goes, and as an economist, I might say from a policy standpoint, follow the money, almost a third of the money is in the hospital sector. So if you want to try to control healthcare spending, that is a place where you've got to begin. It's almost impossible to think about how to control health spending without turning the screws on hospitals, honestly. And physician and clinical services are 20%. Everything else is a much smaller percentage. Now, one could have a big impact if one could tackle each of these little bits and try to reduce waste, try to improve quality, try to improve public health. And, you might find actually you want to spend more money on public health activities, which could have downstream benefits in reducing spending in some of these other areas. But when thinking about policy, following the money is useful. And thus the federal government has implemented and promoted a number of policies to try to reduce health spending. And these have had pretty mixed results. So there has been a lot of discussion about price transparency, that we need to make it more obvious how much everything costs. And thus consumers and employers will pay more attention to the true costs of things, and that'll save us all money in the big picture. And the evidence is, not so much. Price transparency might be needed, but it is not sufficient to really reduce healthcare spending significantly. How about trying to promote competition among providers, right? Medicare Advantage plans are a way to get health insurance plans to compete against each other, or to try, maybe we want to really try to get UCSF to keep competing against Sutter. Could we get some price reduction through more competition between providers? A little bit if you can really get more competition. But if you're not careful, what you also get is more monopoly power. Okay, what about actually just saying we're going to put a cap on price growth and try to do that? That's what Massachusetts has done. California is now beginning to implement health cost targets. And guess what? That seems to work. So, so for a lot of the different things that have been happening around trying to do value-based care and price transparency and so on, those have had some effect, but not a lot. And it's only been these more heavy-handed approaches of just like, we're aiming to have 3% cost growth and the whole healthcare system, we're going to make you go through some terrible, onerous, improvement plan if you don't do better on your cost growth. Those kinds of policies seem to have more effect. So I am going to jump into a policy example that is not as much about cost of care, but just to maybe think about how policies can impact equity and access to care. And this is just from my own research. And I'm going to talk a little bit about some of the places where the research that we've been doing, we think might actually be influencing the state and the federal governments. And so this is just stuff that the team that I work with is really proud of. And I think there are equity implications here. I think a lot of you probably know this background, so I'm going to go through it really quickly. Medications for opioid use disorder, there are 3 different medications primarily used to treat people with opioid use disorder. There's methadone, which is the oldest, been around a long time. It's a full opioid agonist, and it is regulated in general historically to be provided only in licensed narcotic treatment programs, which is a big barrier to access. Those programs are more often found in communities of people who are low income and are racially minoritized, which also has added to the stigma of that medication. Buprenorphine is a semi-agonist. It's also used for pain. As a semi-agonist, it has much less risk for overdose and harms than other opioids. And Suboxone is a formulation that includes naloxone, which is supposed to deter abuse of buprenorphine. And that can be provided outside a narcotics treatment program. Historically, it required a waiver from the DEA, and that policy just changed 1 year ago. Now, any person with a DEA registration can prescribe this without any special permission, but there used to be special permission required. And then there's naltrexone, which I'm going to ignore in the rest of this, but it's an antagonist. It's not a scheduled medication. It is very useful in certain circumstances and for certain patients, but in the evidence and the research, buprenorphine really has the best evidence base behind it right now. That could change, but right now that looks like it has the best evidence base. So there were these waivers, and this was established over 20 years ago, that program. It was established quite a long time ago. Initially, it was only physicians who had to get 8 hours of training to then apply to offer buprenorphine outside a narcotics treatment program. And they were limited to only 30 concurrent patients in their first year, and then they could apply to increase their panel sizes. But there are limits on how many people they could treat, which is interesting. The program ended in 2023, thank goodness. But what we saw in like 2016 was an awful lot of the country, like basically everything that is white and red here, those are counties that did not have a single waivered provider. So in 2016, those are places where there was nobody authorized to provide buprenorphine in their community, which was an awful lot of the US. Why did we have so few? Training time and cost to get the provider, right? I mean, physicians are busy. Oh, go do a training class for 8 hours. Reimbursement challenges, commercial insurance, body coverage. A lot of states did not cover it in Medicaid for quite a long time. And even now there are states that have restrictions of numbers of days supply, prior authorization, you have to see a therapist, etc. A lot of healthcare organizations also created barriers. And then there was stigma. There's a lot of stigma against people with opioid use disorder and also against using medications for opioid use disorder. You would hear rhetoric like, well, you're just trading one addiction for another addiction, without recognizing the evidence base that supports these medications. So policy opportunities are it's hard to have a policy that addresses stigma. So I'll just acknowledge that. Education can help, but that's really hard. But you have a lot of policy opportunity on the training time, reimbursement challenges, and maybe also around organization support of this. Like, what kinds of policies could you implement to get organizations to provide more support? So advanced practice clinicians got added to this in 2016, nurse practitioners and physician assistants. And you might say, wow, why did it take so long? Because in 2015, a nurse practitioner could prescribe OxyContin, but they couldn't prescribe buprenorphine to treat opioid use disorder, which is completely bizarre. But there you go. Why did that happen? Well, you get a lot of stereotypes about different kinds of professionals. You get some paternalism. You get stigma against nurses, gender issues embedding the nursing profession. And we could go down a whole equity pathway on how nursing is treated in the US, but we'll come back. They added the NPs and the PAs. Initially, it was temporary, required 24 hours of training, no documentation or explanation why that. People we interviewed said, I think it's the same training that the physicians do. They just repeat everything 3 times. And then they did expand for physicians up to the 275 maximum patients that year. In 2018, they added midwives and anesthetists and made the waivers permanent, which was good. And in states where these advanced practice clinicians, if they could practice without physician oversight, they could do this without any additional approvals. They could do their training, they could get their waiver, they could go forth and conquer. However, if they were in a state where physician oversight was required, the physician also had to be qualified to have a waiver, which was a barrier for many nurse practitioners in engaging in this treatment for their patients because they had difficulty getting a supervising physician to agree to let them do it. So what states had restrictions or have restrictions now? Basically all the ones in purple on this chart, which just glancing at it, you might notice are some of the states that had some of the biggest problems with opioid mortality, especially in that period of time where most of it was coming from prescription drug misuse. So that really was a policy opportunity. The data showed that mean clinicians per 100,000 population were fewer NPs well, actually, overall, you had fewer clinicians per 100,000 population after NPs and PAs could get the waivers when you restricted their practice to require physician oversight. This is another chart that's basically the same thing, that physician oversight requirement was a real barrier to getting more care out into the community. This was the percentage of total waiver capacity provided by advanced practice nurses. And you can see in some states that had very few restrictions on NP practice that you had much higher percentages in the dark blue of nurse practitioners with waivers. So the evidence that this study, as we've gone along, has been cited. I'm just going to kind of skip through because I know we're running out of time. Has been cited in policy as a known barrier, and some states have considered this as one of the justifications to change their scope of practice for nurse practitioners and amending their regulations, including states like, I think it was Mississippi or Louisiana made some policy changes related to this recently. Also, the training requirements were thought to be a barrier, although some of our research has documented that relaxing training requirements, which happened temporarily during the pandemic, did not really change the number of people providing care. And that other researchers have found that Medicaid barriers need to be addressed and that those continue to be an issue. And that there are big disparities still in access for minoritized populations. And we need to think about what interventions from a policy standpoint we need to address that. What's been neat about all this research that a lot of people around the nation have been engaged in is we are seeing it directly affect policy. And an area where this seems like this very narrow thing where we're going to try to tackle Medicaid just for this, but the access and the outcomes benefits can be significant for a population in need. And a lot of policy becomes very incremental where we just have to move bit by bit as we go along. So I'm going to stop there. And I am happy to stay on a few extra minutes if anybody would like to discuss further. I know that we are at time, though.
Thank you, Dr. Spetz, for that outstanding presentation. Maybe we will give a minute to see if there's any potential questions. Oh, Dr. Opara?
Yes, again, outstanding presentation. We're going to have this available, Mandana, the slides,
yes.
right?
Yes.
Okay.
Yes. I'm going to email them to you. I'll email them to Rochelle and she will that they are circulated. Yes.
That would be great. Real quick, can you speak to Joanne, if you're able to, the role of value-based care within this conversation? And it can speak to a larger conversation around the role, how reimbursement can serve as a lever for implementing health equity policy. But do you think that value-based care is a reasonable vehicle to actualize health equity, or is that still sort of in the imagination phase?
Oh boy. I think personally, I think it's still a little more imagination than reality. But I think one of the difficulties with value-based care is that the financial incentives associated with it really need to be pretty universal to have an effect. I think what a lot of providers are facing now, like if you think about a primary care provider in the community, they've got some patients on fee-for-service Medicare. They've got some patients on, that are in an accountable care organization. So that's a value-based thing. Then they've got some Medicaid patients that might be part of Health Net HMO. And then they got some patients that are on some other, program, or, they're on Blue Shield from their employer. How do you like a primary care clinician isn't going to sit there and say, I'm treating my ACO patients differently because they're in value-based care and I'm going to treat my fee-for-service patients differently. they just tend to practice based on what the overall training that they've had is, the knowledge that they have, and the overall financial reality broadly defined that they live in. So unless you get to a point where you're like, oh no, 3/4 of your population is in a value-based program, or a large proportion is in that kind of value-based care, just trying to, like, the incentive isn't really there to think about a population perspective, and the money isn't there to do the things that value-based care might suggest you should do, like have a community health worker to work with more of your patients. Invest more in prevention and wellness. Maybe you want to hire a dietitian to your clinic, but if they're not reimbursable in a fee-for-service system and half your patients are fee-for-service, the other half that are in value-based care might not be enough money to really justify having the dietitian for everybody. And so that's an area where I keep feeling like it's like you gotta just jump off the diving board and hold your nose and go in and make it work. And until we're willing to do that, I'm skeptical we're going to get a lot of traction in general, much less have the equity benefits that we think we could get from it.
Yeah, I really appreciate that perspective because, currently we have these Z codes for identifying social determinants of health and using them as a way to sort of beef up the complexity of the patient. So when we have a patient comes in, we're trying to get their blood pressure under control, they're also unhoused. And so we document housing insecurity, but that then warrants the extra time and extra care and trying to get social work and other, pull other resources to support them. But if that is not reimbursable because maybe the patient happens to be, like you said, in a fee-for-service, then how do we justify creating care in this sort of integrated, comprehensive, holistic way? That's the challenge I'm experiencing currently because my ultimate focus is clinical practice transformation and change for how do we practice right there on the ground, but how do we use policy as levers for that to happen? And so I appreciate what you offered.
I agree 100%. I agree 100%. Similarly, you think about issues around opioid treatment. It's a lot for a primary care provider to also feel versant and comfortable enough to, provide primary care and good holistic opioid treatment for somebody who has a use disorder. But if you were in a system where you could have a social worker work with that person, or you had the ability to finance a therapist, or even just a peer provider for that individual, you might feel more confident in taking on this work and really engaging in it. But in a fee-for-service reimbursement world, it's really, really hard to do. It's hard to make it happen. And so there are so many different dimensions where really that observation of that colleague about, like, in the UK, the money that goes into the social safety net is much bigger, and that maybe helps counteract that they spend less money on healthcare per se and end up with a similarly healthy population. It's like, I think there's a nice argument to be made there.
Wonderful. Well, thank you very much, Dr. Spetz, for that wonderful presentation and very informative Q&A session. Really appreciate it.
My pleasure.
We look
It's
forward
on email,
yes.
So people are welcome
yes.
to shoot me an email.
Absolutely. Thank you again. Bye-bye, everyone.